Okay, good morning. Today I'm going to discuss with you post-transplant electrolyte disorders in an interactive manner. So this is the outline of presentation. I'll start with introduction in one slide, followed by the cocktail of electrolytes and acid-base disturbance. So I'll give a hint about hyper and hypokalemia, renal tubular acidosis, hyponatremia, abnormalities in serum phosphorus and calcium, and I'll end with hypomagnesemia. Okay, to start with, do you know that the electrolytes and acid-base disturbance are prevalent with renal transplantation after renal transplantation? This may be because of drugs used in renal transplantation. One of the cornerstones of immunosuppressive drugs is the use of calcineurin inhibitor. So calcineurin inhibitors may be associated with electrolyte disturbance in the form of hyperkalemia. Do you know why, Dr. Samar?
Reduced secretion of potassium, or maybe due to overload post-transplant, or
increase the secretion of potassium.
Okay, so the use of calcineurin inhibitor may be associated with a reduction of potassium secretion, and may be associated as well with hyporenemic hypoaldosteronism. So these factors can increase the risk of hyperkalemia after transplantation, metabolic acidosis, and we have principally two types of RTA. Type 1, which is distal RTA, and type 2, which is proximal RTA. Proximal RTA, which is type 2, occurs a little bit earlier after transplantation because of hyperparathyroidism or because of the acute problems after the using of calcineurin inhibitors. Type 1 RTA, which is distal type, is usually related to immunological problems and injury, like rejection or chronic dysfunction related to the chronic use of the calcium inhibitors. Hypophosphatemia, hypomagnesemia, hypocalcemia due to hypercalciuria, all these points, hypos of phosphorus, magnesium, and calcium, are related to increased wasting of these electrolytes by the use of calcium inhibitors. Let me to start the journey with this case. This a 39-year-old woman received a living unrelated kidney transplant and was followed for 18 months. And then the patient presented with hypertension, blood pressure difficult to control. Okay, so this is the most important clinical presentation, hyperkalemia. Medications included tacrolimus, mycophenolate, sulfamethoxazole, trimethoprim, amlodipine 10 mg, carvedilol 25 mg per day. Okay. This table summarizes the laboratory abnormalities. Here, the most prominent one is hyperkalemia, 6.1. So, and mild acidosis here by carb is 21. So, the patient received 30 gram sodium polystyrene sulfonate and sulfamethoxazole trimethoprim. The drug was discontinued. Do you know why? Why they discontinued this drug?
Drug interaction with tacrolimus?
Do you know why? Because of hyperkalemia, and trimethoprim blocks potassium secretion. So in this scenario, it is rational to stop the sulfatrimethoprim to observe the change in serum potassium. And the patient was treated as well by sodium bicarbonate and furosemide. So this is the initial management. What happened in the follow-up? Serum potassium even increased more and more. So serum potassium in the follow-up increased from 6.1 to 6.5. So over the next 6 weeks, the patient's furosemide dose was increased to 40 milligram a day, and the sodium bicarbonate increased to 650 milligram 3 times daily. Her diet was reviewed with a nutritionist, She was also asked to take 15 grams of sodium polystyrene sulfonate with her largest meal of the day. Despite these changes, her potassium level remained between 5.9 and 6.4, hyperkalemic, and her blood pressure remained elevated as well. So it's a case of hypertension and hyperkalemia. This is the first question. Which of the following mechanisms is involved in the development of hyperkalemia and hypertension in this case? Is it depressed GFR? Is it chronic metabolic acidosis? Or the upregulation of sodium chloride cotransporter in the distal tubule? Or upregulation of aldosterone receptor in the distal tubule? Or corticosteroid-induced suppression of aldosterone synthesis? Do you like to answer?
Upregulation of aldosterone receptors in distal tubule.
The second question, which is the best drug to be added in this step? I'll comment on your answer after the second one. Is it thiazides, tyrosine, acetylamide, cansertan, losartan? Which drug is to be added to solve the problem of hypertension and hyperkalemia in this case?
Acetazolamide.
Let me to go to the answer. The mechanism of hyperkalemia induced by tacrolimus includes a lot of mechanisms, as I mentioned in the beginning, reduced potassium secretion. And this slide, the aim of this slide, just to show you the molecular basis of this reduced secretion of potassium. Here, this is the tacrolimus. It stimulates sodium chloride cotransporter within the distal convoluted tubule. After stimulation and increasing the activity of sodium chloride cotransporter, what happens? The sodium is retained, and this can lead to salt-sensitive hypertension. Okay, and with subsequent increasing the reabsorption of sodium, sodium rich in the collecting tubule is reduced. And the sodium rich in this site of the nephron is the main stimulus for potassium secretion. So what happens? Potassium will be retained, hyperkalemia. Another interesting point in this site of the nephron is increasing tacrolimus increases reabsorption of chloride. So if chloride is reabsorption is increased here, there will be a reduction of the negative charge within the tubular lumen. So if the negative charge is reduced in the tubular lumen, again, this will be associated with the reduction of secretion of potassium. Okay. So this is the molecular basis of tacrolimus-induced hypertension and hyperkalemia. If I go to the choices, why depressed GFR is not the case, is not the mechanism in this case, because if serum creatinine is 1.7, the kidney can get rid of potassium. So we don't have hyperkalemia in this range of renal dysfunction. Chronic metabolic acidosis is already corrected, and it is not the case here. Upregulation of aldosterone receptor in the distal tubule. Upregulation of aldosterone can explain hypertension. But if aldosterone activity is increased, what will happen to the potassium? Not hyper. So it does. The upregulation of the aldosterone receptor cannot explain hyperkalemia. Corticosteroid-induced suppression of aldosterone synthesis. If this is with the use of a small dose of cortisone, or prednisone in this case, we cannot expect the suppression of aldosterone release, because prednisone doesn't affect aldosterone axis, it affects corticosteroid axis. So, and to suppress aldosterone, you need big dose of prednisone. So, the corticosteroid-induced suppression of aldosterone will not explain the changes. And even if aldosterone is suppressed, it will be associated with hyperkalemia and not hypertension. So the only, after the explaining the molecular mechanism, the best answer is upregulation of sodium chloride cotransporter in the distal tubule. If this is the molecular mechanism, and this is the pathophysiological defect of tacrolimus-induced hyperkalemia, to treat this pathophysiology, which drug should be used? the drug that inhibit
Active
sodium chloride
chloride
cotransporter within the distal convoluted will be the best drug, which is thiazide,
Thiazide.
because this is the site of action of thiazide. Sure? Perfect. Okay. Let us go to the second case. Take please, deep your breath in and out, please. Deep breath. This is a 29-year-old man received his second diseased kidney allograft, and the immunosuppressive regimen was using almutuzumab as induction Cambath, followed by TAC, MMF, and prednisone as maintenance immunosuppressive regimen. The patient was treated because of rejection by ATG, and he was left with graft dysfunction serum creatinine 2.4 milligram per deciliter. 3 years later, he presented with pulmonary histoplasma capsulatum and was started on voriconazole, which is antifungal, and keeping tacrolimus between 3 to 6 nanogram per ml. This figure shows this is the serum potassium before starting voriconazole. This serum potassium was accepted, but after starting voriconazole, the patient has hyperkalemia. So hyperkalemia, to the extent the serum potassium reached even above 8 milli equivalent per liter. In this point, tacrolimus was discontinued. So this case raises the question of drug interaction between voriconazole and tacrolimus. Do you know the mechanism of this interaction? The previous antifungal drugs like ketoconazole, the old one like ketoconazole, can lead to addisonium problem. So if it suppresses suprarenal gland, it can suppress aldosterone, and it can lead to hyperkalemia. But this is the first case with the use of voriconazole as new antifungal used in transplantation. Again and again, we should be careful about the drugs that we add to the patients, because we find serious interaction like in this case. Another interaction is the use of dabigatran. This is the oral anticoagulant, direct oral anticoagulant drug. And here, after the dabigatran use, the patient has hyperkalemia. And then the patient was treated with fludrocortisone and stopping dabigatran. And after retreating the patient with dabigatran, hyperkalemia resurfaced again. So we should be cautious about the use of drugs. All of us are aware with heparin and potassium. Do you know what is the interaction between heparin and potassium? Is the use of heparin
to hyperkalemia.
hyper or hypo?
Hyper.
Why hyperkalemia?
Potassium based.
It's not.
Preparation.
It is not
Contain
the potassium-based heparin, but because heparin either inhibits aldosterone or inhibits aldosterone secretion or inhibits its action. So this is a mechanism. So we should be cautious about the use of other drugs. Here I'm going to shift to hypokalemia. So this is a 57-year-old woman was referred to a nephrology clinic because of chronic hypokalemia. She had a history of polycystic kidney disease, resistant hypertension, atrial fibrillation, type 2 diabetes, stroke, and end-stage kidney disease, and she received a kidney transplant from a deceased donor at the age of 48 years. At presentation, the patient described symptoms of chronic fatigue, muscle aches, and she didn't report paresthesia. Her medications included 4 antihypertensive agents, so it is resistant hypertension, glucose-lowering drugs, immune suppression, digoxin, coumarin derivatives, and potassium chloride. Laboratory investigation revealed serum sodium is above normal, 146. Serum potassium is below normal, 3.3. And also here, if you look at the urine, there is potassium wasting. So potassium wasting in the presence of hypokalemia means that kidney is the cause of hypokalemia. And this is the aldosterone renin activity and aldosterone to renin ratio. What do you see? Aldosterone is very high. This is normal range between 9 and 555 becquerel per liter, and here we have it is 3000. So it is very high aldosterone, and renin is suppressed. So it is a primary aldosteronism, a case of primary aldosteronism. The message from this case, if you have a resistant hypertension with hypokalemia, we should think of the algorithm, and we should put in our mind the endocrinal causes. So this is a case of overlooked primary aldosteronism, and the radiological workup revealed suprarenal mass. So this is the case. If we have resistant hypertension, we should go in investigation and put in mind primary aldosteronism. And this is this scenario. And after starting aldosterone, spironolactone, blood pressure starts to be controlled. Another case of hypertension and hypokalemia. This is a laboratory analysis 1 month pre-transplantation. Sodium 133, potassium 4.1, but 1 month after transplantation, serum potassium is 3.1 and serum sodium within the high normal range. Okay, so here again, aldosterone is very high, and aldosterone ratio. So it is primary aldosteronism. Another case of primary aldosteronism. Okay, the key message here on renal failure. Renal failure can ameliorate the problem of primary aldosteronism, because in renal failure, the kidney cannot get rid of potassium. So here you can find normal potassium. That is, so the syndrome can be overlooked before transplantation, and it can be picked up after transplantation because of the prominent hypokalemia. So we should put it in our consideration. If I ask you if there is what is the prevalence of hypokalemia in relation to the immune suppressive use, is it more common with calcineurin inhibitor or mTOR inhibitor? Why?
calcineurin inhibitor بتعمل hyperkalemia.
So
mTOR بتعمل hypokalemia.
So this is the prevalence in this meta-analysis. This is the percentage of hypokalemia with everolimus 6%. It is 1.6 with the calcium inhibitor. So calcium inhibitor, the main problem with calcium inhibitor is hyperkalemia, but you can find the hypokalemia in 1.6% of the cases. So again, we should monitor electrolytes. Regarding renal tubular acidosis, this is the case. These are 4 cases of hyperkalemic and renal tubular acidosis. If you look here, where is serum potassium? This serum potassium, it is high and associated with RTA. So the use of calcium inhibitor may be associated with RTA. As I mentioned in the introduction, we may have type 2 and type 1 RTA, and if you find hyperkalemia, maybe type 4 as well, because in type 4 there is hyperkalemia with RTA. But type 1 and type 2, usually there is hypokalemia. And this is the point. What is your expectation? Is RTA more common with calcium inhibitor or mTOR inhibitors?
calcineurin inhibitors.
This study shows that RTA is common and it is equivalent in the group of mTOR inhibitors and calcium inhibitors. So this is why we should look at electrolyte acid-base disturbance among our patients. And this is the nice study, double-blind randomized control trial. Addresses the effect of intraoperative and the early post-operative normal saline or plasma light on hyperkalemia in deceased donor renal transplantation. Here, the use of isotonic bicarb, I want to just say that it is not really isotonic and is not physiological, and it can lead to hypercholoremic metabolic acidosis that may be associated with hyperkalemia. And this was the main prominent results in this study. And this systematic, this is Cochrane review group, showing the review of 6 studies, including 477 participants, the use of normal saline was associated with hyperchloremic acidosis. So should be careful about this, and to put in mind that metabolic acidosis is prevalent as shown in this retrospective cohort. So this is black color here reveals the percentage of patients with low serum bicarb, so it is prevalent. And the most important point is, and bad news, is the presence of metabolic acidosis is associated with what? With increasing the hazards of graft failure, with mortality, and with death tensor to graft loss. So here, if the serum bicarb is low, the hazards increase significantly. So metabolic acidosis is bad news in transplantation. Regarding hyponatremia, hyponatremia may be due to the use of
diuresis,
the using of fluids, abnormalities, the patient is overloaded, etc. So should be careful about evaluation of the patients and to monitor serum sodium. This study shows that hyponatremia is associated with cumulative risk of graft failure. So hyponatremia is associated with bad renal transplantation outcome. In children, hyponatremia may be associated with hypoosmolality, brain edema, and convulsions. So we should put this in our mind. Again, we should search for drugs. This drug, which is cyclotamine, this drug is an antihypertensive drug used in Europe and Korea, and it is similar like thiazide with some vasodilator properties without reflex tachycardia. Its brand name is Transplantation, and this study included 68 patients, transplanted patients treated with this drug, and what they found 11 cases of hyponatremia and 8 cases of hypokalemia. And 3 patients of these patients had combined hyponatremia and hypokalemia. Again and again and again, we should review the medications and know the side effects of the drugs. Regarding phosphorus, the kidney is the main organ of phosphate secretion. The problem in renal failure is renal failure. So in renal failure, there is phosphate retention and hyperphosphatemia. After renal transplantation with the normal kidney, the kidney will get rid of phosphate. So there is a high increasing phosphate secretion. And here I want just to show you the molecular mechanisms. So this is the phosphate reabsorption. So phosphate is reabsorbed through sodium phosphate transporters. Okay? So the sodium phosphate transporters lead to absorption of sodium and phosphate from the tubular lumen to the cell and to the blood. But why there is problems of all of us are aware with hypophosphatemia after transplantation. Do you know why?
Over diuresis?
Yes.
Due to diuresis post-transplant,
Hmm.
there is loss of phosphorus in the urine due to massive amount of urea after transplantation.
And what else?
PTH.
Look at this slide. So the hyperparathyroidism in renal failure, we have hyperparathyroidism that take time after transplantation for resolution. So the high level of PTH reduces sodium phosphate transporter, because as you see here, the PTH will lead to internalization and degradation of the transporters. So it leaves phosphate to be lost and secreted. So this is one of the mechanisms. Another mechanism is FGF23, which is phosphatinine, also reduces the activity of the transporter of phosphate and maybe inhibits as well 1-alpha hydroxylase, and this can lead to increased urinary phosphatic secretion, and reduction in vitamin D will lead to reduction of intestinal absorption of phosphate. Reduction of vitamin D, active vitamin D, also reduces the phosphate transporter. Use of tacrolimus reduces phosphate transporter, High dose steroid reduces the phosphate transporter, so the reduction of the activity of phosphate transporter lead to phosphate wasting and subsequent hypophosphatemia. And as well, after transplantation, we have a syndrome of bone hungry syndrome. And with the polyuria after transplantation and treating the patients with fluid devoid of phosphate can lead to also hypophosphatemia. And the use of antacids can also lead to hypophosphatemia after transplantation. So all these are the mechanisms beyond hypophosphatemia. And this title stresses upon FGF23 because FGF23 is a risk factor for increasing wasting of phosphorus. And if you just remember what I mentioned in the preemptive transplantation, in preemptive transplantation, FGF23 is high, but it's not high like dialysis patients. In dialysis patients, it's very high. That's why the risk of hypophosphatemia is a little bit less with preemptive transplantation. So we shouldn't forget FGF23. This is the so regarding serum phosphorus and transplantation, you can find some contradiction. So this study addresses the issue of post-transplant hypophosphatemia and the risk of death-censored graft failure and mortality after transplantation. Here, as you see, if the presence of hypophosphatemia here, if it is absent or mild and severe, what happens? The hazard ratio for graft dysfunction is less. I think it is rational. If the graft function is nice, this will lead to hypophosphatemia. So hypophosphatemia in the early period after transplantation may only reflect the function graft. So this is one of the point. Another point, if you find a hyperphosphatemia after transplantation, it is bad news. Why bad news? Because it may be associated with cardiovascular and graft dysfunction. Let me go to this case because it carries a very interesting message. So this is a case of transplantation. After these weeks of transplantation, here serum phosphorus is nearly undetected. So it is a case of severe hypophosphatemia after transplantation. We don't like severe hypophosphatemia because we are afraid of muscle problem, hemolysis, fatigability, etc. So this is why the patient was treated with phosphate. What happened? After treatment with phosphate, creatinine increased. So the patient had acute graft dysfunction after treatment with phosphate. Is it rejection? Is it related to the use of phosphate? We don't know. So biopsy was carried out, and the biopsy revealed the presence of a stuff within the dilated tubule. So this is a case of tubular injury with this stuff, and this stuff was stained black with vancosa. Vancosa stains phosphate, and alizarinide stains calcium. So it's a case of calcium phosphate deposition within acute tubular injury. So it's a case of acute phosphate nephropathy after treatment of hypophosphatemia. The key message is, yes, we don't like severe hypophosphatemia, but we should be meticulous in treating these patients with monitoring of serum phosphorus and avoiding the excess use of phosphate, because this may be associated with bad consequences. Regarding hypercalcemia, and this study shows that hypercalcemia after transplantation is prevalent. Here, within a year, it is 16%. Within 2 years, it is 13%, even up to 48 months. This means 4 years is 10% in this Canadian study. And this is a nice case. This is a case of hypercalcemia after transplantation, 3 years after transplantation, for a patient who developed pneumocystis carinii pneumonia. Laboratory investigation revealed creatinine, this is calcium, 3 millimole per liter. What does it mean, serum millimole per liter? What is the equivalence in milligram per deciliter?
Multiply by 2.
Multiplied by 4.
By 4.
To millimole, to transfer millimole into milli equivalent, we multiply by 2. 2 milligram per deciliter multiplied by 4. So 3 millimole per liter equals 6 milliequivalent per liter and equals 12 milligram per deciliter. So the case of hypercalcemia with the infection 3 years after transplantation. The beta H is 13, so it is no normal. So if I ask you, what is the mechanism of hypercalcemia in this case?
due to hypoparathyroidism.
It's not hypoparathyroidism. It's not hypoparathyroidism. It was a normal. But if I agree about hypoparathyroidism lead to hypo or hypercalcemia.
Increase hypocalcemia.
Hypocalcemia and hyperphosphatemia, not hypercalcemia.
Yes.
So what is the mechanism? The mechanism is related to increased vitamin D. Why active vitamin D is increased? Because with pneumonia there is macrophage. So macrophage can release 1-alpha hydroxylase. Releasing 1-alpha hydroxylase will activate vitamin D and increase the level of active vitamin D. And one of the problem of 1-alpha hydroxylase released from the granulomas or infection like this is it is not amenable to physiological regulation. So 1-alpha hydroxylase released by renal tubules is under feedback and control. But when alpha hydroxylase released by macrophages is not amenable for this feedback. So the treatment in this case is to support the patient, and the definitive treatment is the key of success. So after treating pneumocystis carinii with cotrimoxazole, the patient condition improved and serum calcium was corrected. So the cause of hypercalcemia in this case is production of vitamin D by the inflammatory, by infection. So these are the cases of unexplained hypercalcemia, and after thorough investigation, the diagnosis of pneumocystis carinii, and then the new name of pneumocystis carinii is pneumocystis jirovecii pneumonia in transplantation. So hypercalcemia in these cases precede the diagnosis. So if we find hypercalcemia, yes, we can manage symptomatic hypercalcemia, but the most important point is to put the algorithm for the mechanism of hypercalcemia. And according to the cause of hypercalcemia, if it is infection, treating infection, is granuloma, treating granuloma, if malignancy, treating tumors. So this is the rational thinking to think of the etiology. And if we wanted to treat symptomatic hypercalcemia, we can use cinacalcet as calcium sensing receptor stimulation, so it can ameliorate hypercalcemia. And even if the case is refractory, we can think of parathyroidectomy if there is hyperparathyroidism persistent after transplantation. A very interesting case. It is virtual case and not an actual case. This is a patient who present with asymptomatic hypocalcemia, severe hypocalcemia, total serum calcium is 3 milligram per deciliter. And this is 2 hours after doing magnetic resonance angiography to diagnose resistant hypertension. My question to you, what is the mechanism of hypocalcemia in this case?
Contrast reduce.
Why? What's the link between the gadolinium used in magnetic resonance angiography and the hypocalcemia? The link is, as you see in these articles, it is a case of hemodialysis patients, severe pseudohypocalcemia after gadolinium enhanced magnetic resonance angiography, and this is another case of pseudohypocalcemia in hemodialysis patient. So this is because gadolinium interferes with calorimetric methods for detection of calcium. So if we depend upon calorimetric measures, this will interfere. Gadolinium will interfere with this detection, leading to severe hypocalcemia. And the key of diagnosis of pseudohypocalcemia is absence of numbness, tingling, paresthesia, and the patient was completely normal. So the message is if we give the patient gadolinium,
Don't order calcium.
don't order
testing.
serum calcium, except if the patient was treated from hypocalcemia. And if we order serum calcium within the short period after gadolinium, it's better to use non-calorimetric method that will not be amenable for the interaction with gadolinium. So again, hypocalcemia may be a problem after transplantation. We should put in mind. Sometimes we find recalcitrant or severe hypocalcemia that mandate using of teriparatide or recombinant PTH therapy for treating severe hypoparathyroidism after transplantation. And nowadays there are case reports about the use of parathyroid transplantation for treating hypoparathyroidism for treating these cases. The KDIGO recommendations stressed upon the abnormalities of calcium and phosphorus. So in patients after transplantation, the recommendation is to monitor calcium and phosphorus after transplantation at least on weekly basis. And this recommendation based on moderate evidence of research. In patients after the immediate post-kidney transplant period, it is reasonable to base the frequency of monitoring serum calcium, phosphate, and PTH on the presence of magnitude and the magnitude of abnormalities and the rate of progression of CKD after transplantation. So the message is we should put calcium, phosphorus in our mind. The last sector of this presentation is hypomagnesemia. Is it common after transplantation? One of the most interesting reviews discussing the issue of hypomagnesemia after transplantation is this review. And as you see here, for this number of patients after transplantation, the white squares reflect the value of magnesium before transplantation. And the blue squares here reflects the value within 2 weeks after transplantation. What they observe is after transplantation, the tendency for hypomagnesemia is common in these patients. And I want to say to you that hypomagnesemia is associated with many problems. So after transplantation, hypomagnesemia may interact with parathyroid, leading to hyperparathyroidism, with pancreas, leading to diabetes, with graft dysfunction, bones osteoporosis, impairing the immune system and be associated with infection. So hypomagnesemia has many crosstalks with different organs. And this is clinical study shows in pediatric that fractional magnesium excretion is increased. So the rate of hypomagnesemia in these patients on tacrolimus, 43%, on cyclosporin 33%, and the rate of hypermagnesuria is 64% and 66%. So 2/3 of patients treated with calcineurin inhibitors show hypermagnesuria. So magnesium wasting through the kidney by excess potassium secretion. So should put this in mind. The last point that I want to address, this is the systematic review and meta-analysis, including 5 cohort studies. 1699 patients showed that hypomagnesemia is associated with post-transplant diabetes, maybe due to insulin resistance or other etiology. To sum up, this is the key message. With following up the patients after transplantation, we shouldn't forget electrolytes and acid-base circuits. Why? Because they are prevalent after transplantation and they can be associated with many problems. So we should think and just monitor our patients in a proper way. And this presentation was delivered within the conference of the 7th ISN Emeritus Medical Association Nephrology Update, and I was honored to deliver this presentation on Thursday, the last Thursday, and I appreciate the invitation of the organizing committee, especially Professor Mona Rukhemi, and it was my pleasure and honor to participate in this meeting. And if you have any question regarding electrolyte disturbance after transplantation, please do send me your question through my email. And thank you very much for your attention. And goodbye.